What is rehab or rehabilitation? My name is Fred Bigueras, a board-certified sports and spine medicine physician in Virginia Beach, Virginia. After 10 years of practice, I still find musculoskeletal medicine both fascinating and challenging. This podcast is about the lingering thoughts and questions I've had after residency and fellowship. My hope is to spark discussion, challenge dogma, and share my experiences in musculoskeletal medicine. Welcome to the Talking Rehab podcast. Okay, thanks again for listening. I wanted to talk about this particular topic as most pain syndromes are attributed to a specific event. Fall, getting bumped into, car accident, things like that. But I want to talk about inactivity. And I'm not talking about, being physically inactive or, not exercising. I'm talking about the relative inactivity from someone's day-to-day movement. I believe that the body is used to a certain amount of movement in a particular pattern on a day-to-day basis. And when there is a disruption to this pattern, the body can develop symptoms such as pain and stiffness. And it is a very common cause in my clinic for symptoms, but I believe that it's not accepted or recognized by physicians and even patients as a potential problem or culprit. So I wanted to dedicate this episode to talking about inactivity as a trigger for pain. I came across this phenomenon after I saw people with pretty severe pain coming off of prolonged hospitalizations. So as an example, if someone had the flu and they were down for 2 weeks, or they were actually in the hospital with a pneumonia and they were in the hospital for about a week, they never went in with pain symptoms, but when they started to recover, they got out of bed and they're starting to walk, it's natural to expect some aches and pains. Joints and tendons can feel sore from inactivity. That to me kind of made sense in terms of you just have to kind of shake things off. However, I had a series of patients that had underlying osteoarthritis of their knees, and they never really had problems with arthritis prior to this hospitalization. But when they got out of the hospital, man, the knee pain was just out of control. So they would come to my clinic, and I would have this big workup of, did something happen in the hospital? Was the knee pain due to a trauma? Was there some sort of medical procedure that was performed that had some unexpected consequence that might have precipitated the knee pain? And a lot of times, there's no way to really prove anything, or all the imaging studies come out to be normal. And eventually they do improve, but that ultimately was what tipped off this whole idea of, was this hospitalization, being down and out for a week or two, the trigger for these symptoms? And then over the years, I noticed it being a pattern. Have these really severe pain episodes that kind of came out of the blue. And the more I ended up talking to the patients, I started to hear a little bit more of the backstory. There was, a completely unrelated medical procedure that was elective, went fine, but as a result, it caused them to be very inactive for a defined period of time. Every now and then, I'll have someone who has a series of these events. They had let's say a hernia repair, rotator cuff repair, and then they went on a long trip to Europe, and let's say like a 12-hour car ride or something like that. And those series of events, even though they healed well from the medical procedures, they're still not back. They never really return back to their previous level of activity. And then a year goes by after having, these events happen, and all of a sudden they're having really severe back pain, severe hip pain. I do the full workup of imaging. Nothing comes back acute. Of course, I start to see some degenerative changes, and, the thought is, well, is it coming from that? And it's very difficult to say. So I feel like it is a very slow creep of inactivity where someone has a insult to their body, but they never really reached their previous level of activity. Their body makes certain changes, and then they get hit with another period of inactivity, and then it slowly starts to limit people's motion, and then we're off into a vicious cycle of pain. Inactivity has a variety of side effects. Again, let's use this example of someone in the hospital with a pneumonia, something completely unrelated to an orthopedic or neurological problem. They're in the hospital for about a week. The changes to the body that can happen in a short amount of time include contracture formation, atrophy of the muscles, deconditioning, poor exercise tolerance, abnormal mechanics, and then as a result, increased pain or decreased pain tolerance. Is probably a better way to describe it. So you take these effects side effects of inactivity, and then people start to try to get active again. These factors can sometimes trigger these pain syndromes. When someone has underlying arthritis or tendinopathy, but particularly with arthritis, I find that this is a very common presentation. I also noticed with time that this ability to recover from prolonged inactivity periods becomes harder to recover with age. So use this as another example. When you're 20 years old with the flu, you bounce back. But then when you're 40 years old with the flu, it takes a much longer time to recover from a cardiovascular standpoint, right? I think the same phenomenon occurs from a musculoskeletal standpoint. Relative inactivity is much easier to deal with when we're younger compared to when we're older, and also easier if you have quote-unquote normal-looking parts versus abnormal-looking parts. In terms of, or the analogy I have behind this, I kind of look at our joints as moving parts or joints or gears. And rusted parts, our parts become rusted with time. They still work, but you do have to keep them moving. Even with completely normal-looking parts, if you give it enough time, the parts will start to move kind of stiff and feel unnatural. Until you get to a point where you are consistently moving those parts again, it'll start to smooth out. Imagine a brand new fire hydrant that was placed in the neighborhood. And in order to open up the water, if you do it day one, things move pretty smoothly. But you imagine weeks, months, even years at a time, and now you're trying to open up the fire hose or the fire hydrant. You can imagine how difficult it can be. And I believe the same phenomenon occurs in the body, which eventually manifests as pain. This whole concept of inactivity, I feel, exposes a blind spot or a bias that we have, because we, as clinicians and patients, we acknowledge that if something is supposed to move, you should keep it moving so that it keeps moving. As an example, a car that is in the garage for a long period of time, we know that it's probably a good idea that we start it every now and then just to make sure that the parts stay moving and things don't settle and we don't start to get weird sounds coming from the car. Yet, as humans, I think we have a hard time seeing that in ourselves. And even as clinicians, I think we have a hard time acknowledging that as a potential trigger of symptoms. So you can imagine how this plays out in the clinic. Patients are frustrated because they are hurting and they need an explanation. Physicians and physical therapists are trying to reassure their patients with their education, but the unfortunate truth is that reassurance sometimes is not enough when you're hurting. The only way to scratch that itch is to get an MRI. Now, on top of that, you have to deal with the bureaucracy of trying to get an MRI, which can sometimes disincentivize patients from doing that. And here we are stuck in a vicious cycle. I kind of went off on a tangent there, but at the same time, I think that it's relevant. As clinicians, we have to acknowledge that inactivity is a trigger. If we don't, why should we expect our patients to believe that too? So I look at it as there are a couple different things we need to do. Number one, we have to believe that inactivity is a problem. Number two, we have to then prove it to ourselves and to make sure that there are no other acute issues going on by getting advanced imaging, x-rays, MRI, CTs, which can also take time. And then once we have that information, then we can start to really gain some patient buy-in, but also start to convince them that there is no structural problem and that we have to consider other issues such as inactivity that ultimately is the culprit of their current symptoms. It's a lot of steps and can take a while to convince clinicians, let alone patients. And even if we know that inactivity is the cause, it's still a diagnosis of exclusion. It's not a structural problem. Yet we still have to get imaging in a lot of cases to prove to patients that there is no acute structural problem, and also to essentially gain buy-in from them. Because if they don't have that buy-in, fear and pain will dominate the rehabilitation program, and that just puts everything on the back burner. It also gives the appearance that we are being very dismissive of their symptoms by not taking them seriously. So I encourage all of you to start looking for it in your patient population. If you're a patient listening to this, start thinking about your own history, about how your symptoms might relate to a slow creep of inactivity into your day-to-day movement and life. The sooner that we all acknowledge this as a problem, we can start to address it specifically. I hope that this was helpful, because the more that I think as you grow in your clinical practice, or if you're a patient that is listening, even though your symptoms seem to have started 3 months ago, I think for a certain portion of you guys, if you start to dig a little bit deeper, you'll kind of start to see this slow seeping inactivity that occurred over a couple months. And I bet you that if you kind of look at it from that standpoint, your symptoms might make a lot more sense. But I'm very curious to hear your guys' thoughts. I know that this is kind of a concept that can be difficult to understand and to accept, but I encourage you guys to share your stories, reach out to me either over email or social media. I am really very interested to hear more about your experiences. Thanks again for listening. Thank you for listening to the Talking Rehab podcast. I hope that this podcast stimulates you to question your own practice and how you approach rehabilitation. I truly appreciate your time and attention. If you enjoyed listening, make sure to like and subscribe to the podcast. I wish you a movement-filled day. Take care.